Hello, YouTubers. Welcome to my channel, Lady Nephrology, where we talk all things nephrology. Today, we have the fabulous cardiac expert, Penny Zimmerman, and she will give us some insight on heart failure and kidney disease. In the medical world, we call it the cardiorenal syndrome. Penny Zimmerman is a board-certified acute care nurse practitioner. She has been in practice as a nurse practitioner for over 17 years and a nurse for over 23. She received her BSN from James Madison University in Virginia. And after nursing school, she worked at the bedside caring for patients in the coronary intensive care units and cardiovascular recovery units. She received her MSN from the University of South Carolina, Columbia, where she wrote a master thesis entitled A Comparison of Manual Compression versus Pneumatic Compression Device for Achieving Femoral Artery Hemostasis After Inpatient Cardiac Catheterization, a Pilot Study. After graduation, she worked as a cardiac nurse practitioner for 8 years. Additionally, she has experience with advanced heart failure, having collaborated with heart failure clinics while she worked as a nurse practitioner for hospice and palliative care. She is now employed by DaVita Integrated Kidney Care, where she integrates her knowledge of cardiac patients with end-stage renal patients to help manage their care doing risk assessment consultations. So let's welcome Penny Zimmerman to Lady Nephrology. How are you doing today?
I'm great. Thanks for having me. I'm happy to be here.
And I am so happy that you are here today because you are our cardiac expert. And since I've been working with you, I've really learned so much about cardiac and cardiac disease, and also how it correlates with kidney disease. So thank you so much. And so let's get started.
Okay.
All right. So for our viewers, what is heart failure?
So heart failure is, it's a broad term. It's a general term, and it usually signifies that a patient's heart isn't working like it should. And because it's kind of like a broad term, there's not really, there's a lot of different types of heart failure, but most people, when they hear heart failure, associate heart failure with their heart not pumping very well, or there's something going on either with the relaxation or squeeze of their heart. Most people think of heart failure that the heart is not working like it should. So that's basically in a nutshell what heart failure is.
All right. And so what are the stages of heart failure?
You know, there's a lot of stages. And so I guess for purposes of this, what I will kind of refer to as heart failure is either a problem with the pumping or a problem with the relaxation of the heart. So if you can kind of back up and think about what heart failure is a little bit differently, heart failure, if you're looking at it, the heart is a muscle just like any other muscle in the body. And so when it is working, what it's doing is it's pumping and relaxing. And what it's pumping out is blood. And when it's relaxing, it's filling with blood. And there are multiple sides to the heart, multiple chambers or holes in the heart that, or I guess compartments in the heart is a better way to say it, that open and fill and then squeeze and push out blood depending on what part of the heart it's in. So when you're talking about stages of heart failure, one of the important things to understand is how bad is it not working and how bad are the symptoms that you may be having related to the heart failure. So when you're talking about stages, most people say that you have stage A, which is you don't have a history, but you have risk factors for it. You might be having some high blood pressure, diabetes. You may have had a heart attack. You might be overweight or obese. You may have a history of smoking or rheumatic heart fever. Bunches of different things can cause heart failure, but you haven't had any of the symptoms of it yet, and you haven't had any structural changes in your heart. The second stage is more where you have the changes in your heart, the structure of your heart and how it is shaped or how it's positioned, how things are positioned in your heart might be a little bit off. And so it's not going to be working as well. So you have the structural changes, but you may not have had ever any symptoms. And that's this kind of the second stage or stage B of heart failure. The third stage of heart failure, stage C, is where There's structural changes in the heart. So your heart isn't working quite as well as it should because of the structure is not normal, but you have had symptoms. So when you have symptoms of heart failure, a lot of times people will notice that they are swollen. So their legs might swell. When they get up and they walk, they might be a little bit more short of breath. Maybe they can't lay flat at night. They're having to, sleep on a couple of pillows, or they wake up short of breath. They're just feeling off. Sometimes people will have chest pain or chest tightness. Sometimes people will cough and have like this kind of dry hacking cough. So there's a number of symptoms that people can have with heart failure. But with the third stage, you don't necessarily have to have active symptoms. You just have to have had a history of it. You could be well controlled with heart failure. That's the good news. So stage C is where you have the structural changes, but you may or may not have symptoms actively going on right now. The fourth stage, which is called stage D, is more of the end stage heart failure. And there's dramatic changes in the structure of the heart. And so with that, the heart isn't going to repair itself. It's not going to be well managed. Even with medications, it can be stabilized a little bit, but the problem is that because there's a feedback system in your body with the heart that allows you to kind of maintain what we call homeostasis or stability, that gets out of whack. And so a lot of times when you have stage D or end stage heart failure, it requires a lot of medication. It requires sometimes a lot of advanced therapies. So you may have a defibrillator put in, you may have a pacemaker with a defibrillator put in. You might end up having to have some conversation about some really aggressive treatments. Maybe you have an artificial heart, or maybe a doctor wants to talk to you about getting a heart transplant. And sometimes for patients, those aren't options for them. And so then they have to have some conversations about, okay, so then if we're not going to be aggressive about that treatment, what is the end of our life going to look like? How can we write a good chapter now, given the kind of hard cards that we've been dealt? So that's stage D, and that's more of the end stage. So it's kind of on a continuum. Heart failure is from, at risk to, end of our life, and any step in between there, depending on what the heart is doing and how well it's working.
So what are the types of heart failure?
That's a great question. So, if you think about it, I think of when we're talking about heart failure, most cardiologists, or, there's a couple of different heart failure types, because your heart is an organ that is divided between the right and the left side. So when you think about the heart, think about like an organ in your body. It sits in your chest that is shaped like a football. A normal heart is shaped like a football. And the heart itself is divided vertically and it's divided horizontally. So when the idea of heart failure is introduced, most of the time we're talking about the left bottom chamber of the heart not working well. It can happen on the right side too, but most people, when we're talking about it and thinking about it, we're talking about what is the bottom main pumper on the left side doing and what is not working. So the two types of heart failure that we focus in a lot is one called systolic heart failure and one called diastolic heart failure. Now, those are kind of technical terms, but really what it boils down to, is it a problem with the left ventricle, the left main pumping chamber? Is it a problem with the squeeze of the heart, or is it a problem with the relaxation of the heart? And so the systolic heart failure is where your heart is not pumping blood very effectively. And so it's not emptying very well. And when it doesn't empty well, it doesn't shoot the blood out to the rest of our body for our other organs to be fed with oxygen-rich blood. And so things start to get backed up and it starts to kind of swell and you get swollen, and a backed up system doesn't work very well. The other kind of heart failure is diastolic heart failure. And that's a problem where that left ventricle, that main pumping chamber, doesn't relax very well. A lot of times people who have a history of uncontrolled high blood pressure, when they're not taking their medications like they should, or it's not recognized, when the patients don't have recognized high blood pressure, the muscle wall itself starts to thicken, and thick muscles, big beefy muscles, don't relax very well. So when you don't relax very well, you're not going to fill. There's not elasticity in that muscle. And so when it doesn't fill, it's going to backtrack to where the blood came from. And so that's when you start to have those symptoms too that we talked about earlier.
So
So
what's
you
the
can have
EF on those? The
yeah,
EF
so
systolic and diastolic?
yeah. So ejection fraction is kind of a technical term that cardiologists and people in the medical world use to talk about how well the blood is emptying from the ventricle, from that main pumping chamber. So it's important to kind of know normal. Your heart, the left ventricle, the heart doesn't empty all of its blood that it contains. That would be a bad scenario. That would be a bad thing. So a normal heart in the left ventricle empties about 55 to 60% of the blood it contains. So about half, right? When you have a pumping problem, a systolic problem, the ejection fraction is low. So you can have anything less than about 50% is considered systolic heart failure. Now, it starts to get progressively worse because I have seen patients where their ejection fraction, the amount of blood being pumped out, is down to something like 5%. Now, obviously, those are really, really sick patients. They're nearing the end of their life, but they can get down that low and they can live a while with that. Most people, when they start to have problems, their ejection fractions are usually about 40 to 45% and below. When you have people who have problems with the relaxation of the heart, then the ejection fractions are usually normal or actually can be elevated because that heart is really big and beefy and it's pumping and doing its job, but it's not relaxing very well. So the ejection fraction, the amount of blood being pumped out, is going to be normal. So about 55% or even higher. Sometimes you can see it 75% and never really seen 80 too much. It was one person that I saw 80%, but it definitely, the numbers are a lot higher than normal, either normal or higher.
Okay. What are some complications of heart failure?
So heart failure is a big problem in the country because heart disease is the leading cause of death in the US at least. And so complications often, when you're looking at complications, it really kind of depends on how severe the heart failure is. So when you have early stages of heart failure, what gets complicated is that you may not be able to have as much activity as you used to do. You might have some problems with your heart communicating with the rest of your body, specifically your kidneys. You're not feeding your organs as well as you should. And so a lot of times heart failure is associated with poor kidney function. Certainly hospitalizations can cause complications. The more times you go in the hospital, the more you're going to get exposed to things that you normally don't get exposed to. And so hospitalizations increase and things like that. When you start to look at some of the more advanced therapies, you start to have problems with medication tolerance or balancing some of those things. You might have problems with reduced immune function. You're more susceptible to infections, especially with COVID these days. A lot of people with heart failure really need to consider, getting immunized against COVID, and the rest of the preventable diseases like flu. You can also have problems with complications if you've got devices. So if you've got a pacemaker in your chest, or you have a defibrillator, you can have infections related to that if you're not careful with your immune system, and you can develop heart rhythm issues. So again, because the heart's not pumping like it should, it puts you and predisposes you for heart rhythm issues. Some of those issues they're annoying and they need to be treated, but they're not necessarily life-threatening. And then there is another set of heart rhythm issues that can be lethal and can be life-threatening. And so that's one of the things that we always kind of watch out for to make sure that somebody is not having. So those are usually the complications that we see most often.
And how is heart failure diagnosed?
That's a great question. So a lot of times, a lot of people don't realize that they've had heart failure. Again, your early stages, you're having the symptoms or the risk factors. So a lot of times when people come into the hospital, they may complain of some tiredness or shortness of breath or swelling. And oftentimes the initial thing that we find out that someone's in heart failure with is that we do chest x-rays. and EKGs. So chest x-ray is just a x-ray picture of your lungs, and we see fluid in your lungs because it's backed up, it's not going forward. And so when blood flows through the heart, one of the places that it comes from is the lungs itself. And so when you think about backtracking that system on a congested system, the fluid builds up in the lungs. And so we start to see actually fluid in the lung tissue that indicates somebody may have heart failure. And then EKGs, when we do an electrical picture of the heart and the heart rhythm itself, sometimes we can see some changes there that may indicate some type of history of heart problems. But the gold standard for looking at heart failure and what kind of heart failure you have, or how severe it is by a test called an echocardiogram. So an echo, or echocardiogram or echo for short, is a sound wave test. And I always describe it to patients that it's kind of like when you get an ultrasound of, when a mom gets an ultrasound of the baby in the womb. That's what it is. It's a sound wave test that goes on top of your chest. They rub some jelly on your chest and put what we call a transducer or a sound wave detector on that chest, and they can take pictures of the heart and how well it's working through that sound wave motion. And so the echocardiogram tells us a lot of things about the structure of the heart, about whether the heart's relaxing well or squeezing well. It tells us about the structure of the muscle itself. And it also tells us a lot of structural change, if there's structural changes in the valves or the blood vessels that are coming to the heart and going away from the heart. So the echocardiogram tends to be the gold standard that we use, that once we have a suspicion that somebody has a heart failure, that we look to get.
All right. So what is the management? So once a person is diagnosed, what is the management of heart failure?
Yeah. So, there's a lot of different prongs of treatment. The first thing is medication. And oftentimes, depending on how significant the heart failure is, you have to add more medications. Kind of the gold standard is, if you have heart pumping function that's reduced, or systolic heart failure, the gold standard is that you're going to be put on beta blockers, which is a class of medication. So examples might be metoprolol, atenolol, carvedilol. So most of your medications, if it ends in OL, then that's probably in the class of beta blockers. And what those medications do is it reduces the workload of your heart and makes it a little bit more efficient. It lowers your blood pressure, it lowers your heart rate, and allows the heart to do its job better. The second kind of medications that we use are called ACE inhibitors, and those are the medications that end in PRIL. So enalapril, lisinopril, fosinapril. Those are medications that act on the kidneys and tell the kidneys to tell the heart, it's okay, we got this, we're going to work a little bit better. So there's a lot of chemical talk in between the heart and the kidneys that goes on. And those ACE inhibitors improve the communication going to the heart. The other thing that we put people on is what we call diuretics. And so unfortunately, a lot of people, because they've got too much fluid, and because the heart is not pumping very well and the kidneys aren't clearing very well, we have to put you on a diuretic. And a diuretic is a medication that makes you pee. Unfortunately, we got to get rid of the fluid somehow. And so those medications, there's several, Lasix or furosemide, torsemide. There's also other kinds, hydrochlorothiazide, that you might see people on. Those are usually some of the most common. And then one of the new ones that we're starting to see on patients that are first line medications is a brand name of medication called Entresto. And it's a little bit different from all the other classes of medications. It has a relative, I call it kind of the redheaded stepchild of ACE inhibitors, an ARB, an angiotensin receptor blocker is the fancy name for it, called valsartan. So it's a combination drug. It's a 2-for-1. You have this ARB or valsartan medication combined with another medication called sacubitril. And it, again, improves that chemical communication between your kidneys and your heart to be able to clear out that system and clear out the congestion better. That's typically the core medications that we use on everybody. There's other things that we can add, but a lot of beyond the medication is lifestyle. and consistency with your medication, avoiding a lot of fluid, drinking a lot. These medications unfortunately do cause a lot of dry mouth and a lot of problems with, reducing your blood pressure. So a lot of people are thirsty, and so they want to drink more water, and that's kind of works against the whole purpose. So you have to be careful with your fluids. You have to be careful with your salt, because salt and water, I always tell my patients, salt and water are best friends. And so you got to reduce the amount of salt that you're bringing in, and then making sure that you're doing exercise. I am a huge fan of cardiac rehab. Cardiac rehab is a program, usually with physical therapy, that works with patients who are newly diagnosed to allow them to learn how to exercise where it's safe for the heart. So that's usually the kind of the multi-pronged approach to treatment. And there are more depending on how severe the heart failure, but for people who are kind of starting out on that process, that's what we usually recommend.
What about alcohol use in heart failure?
Oh, good question. Good question. So one of the causes, or one of the risks of heart failure, is alcohol use. Alcohol, when we ingest alcohol, the alcohol itself ends up being a toxin in our blood. And so when we ingest alcohol, it goes to the liver. And when the liver starts to break down the alcohol, there are chemicals that are made in that breakdown process that are toxic. And they can be especially toxic to the heart. So if you have a lot of alcohol intake, if you consume a lot of alcohol, you raise the toxin level in your body, and it basically attacks your heart. And when you have that toxin attacking your heart ends up getting big and floppy. So you end up developing heart failure. Now, sometimes if you stop alcohol intake, your heart gets better with treatment, with medications. Sometimes it stays the same. Occasionally it gets worse depending on what other medical problems you have. So alcohol use, it does a couple of things. Number one, it adds a toxin, so you should avoid it. But also it's a lot of fluid. And so when you're trying to maintain a lower fluid intake, adding fluid with things that you don't necessarily need, you can get fluid other ways, is kind of, again, working against the purpose of treatment.
All right. So what is the prevalence of heart failure in end-stage renal disease patients?
Yeah, so, the heart and the lungs, the heart and the kidneys are really, they're kind of partners in crime, so to speak. And so, if you have heart problems, then you're probably going to have kidney problems, and vice versa. We see a huge prevalence of heart failure in the renal population, not just in end-stage renal disease with people who require dialysis, but people whose kidneys are starting to kind of act up a little bit and not work quite as well. So a lot of chronic kidney disease patients will have increased rates of heart failure. One of the recent statistics that I saw on a presentation I was recently giving is that all end-stage renal failure patients, if their fluids are not managed, they will develop congestive heart failure. So that was 100% of people. And that's a pretty scary statistic, because when you think about that, if you're on dialysis, you're already assuming that you have existing heart failure. Now, how bad it is depends on how well you do with management of that kidney disease, but they go hand in hand very frequently.
So what are the outcomes, patient with kidney disease and heart failure? What are some of the outcomes?
Yeah, so when you're looking at outcomes, one of the things that we want to do is we obviously want to reduce hospitalizations. We want you to stay at home. We want you to be happy and healthy where you are. When you're living with a chronic disease, there's nothing worse than kind of feeling tied to this disease process. And it kind of becomes this thing where it defines you. So one of the biggest outcomes is we want to reduce hospitalizations. We have to do that with medications and lifestyle management. There's no other way around that. And so when you're looking at outcomes, you want to make sure that you're doing and asking the right questions, working with your nurse practitioner, your physician assistant, your cardiologist, and managing the heart failure so that you can stay out of the hospital. A lot of times there are high readmission rates. So if you go into the hospital with heart failure and it's oftentimes that you get readmitted within the 30 days. And that's obviously costly to the general public, but it's very costly to you too, because then you're on the hook for a hospitalization that probably could have been prevented. So from a hospitalization standpoint, outcomes are really important. When you're talking about outcomes with CHF and with kidney disease patients, again, it depends on how severe the kidney disease is, and it also depends on how severe the heart failure is. Eventually, death and disablement are very, very high if it's not well controlled. So these are diseases that a lot of people, unfortunately, pass away from. And so it's important to understand that the more severe these diseases are, the higher your risk for death and dying. And so when we're talking about outcomes, a lot of that is based on, again, the severity of both of those components and how we can better manage you.
Any last or final thoughts on the subject of heart failure and kidney disease?
I will tell you this, I have dealt with heart failure patients pretty much all my career. And, it is a disease that is very, very common, but it's intense. And when you're dealing with already an intense disease, and now I'm seeing patients in the end stage renal population, which is an also equally intense disease, it can be really, really tiring. And so you kind of have to keep your focus, you kind of keep your eye on the prize. Really what I would encourage people to think about is keep your eye on the prize for improving quality of life. You don't want to not do what's recommended, because ultimately what's recommended to you is based on studies and data that improve quality of life. So most people, I don't know anybody who's ready to pass away. I mean, most people, even in hospice, I was dealing with people who were pretty close to death, and they still weren't ready. So when you're talking about dealing with chronic illness, keeping your eye on the prize, how can I improve my quality of life? What's going to enable me to kind of live my life as much as normal as possible? And some of that requires finding some new normal and resetting, your own expectations of what you need to do and how you need to manage that yourself. Ultimately, you're the driver of a lot of decisions that, may impact you down the road. And it's important for people to take an active role in their healthcare, get educated about it, listen to your YouTube channel on how to be able to take better care of yourself, ask questions, and have an advocate for yourself or with you when you go in to see your doctor, so that you can bounce ideas back off of. So really it's about, quality of life and education to kind of help move you forward and keep you happy and healthy.
All right, Penny, that was excellent. Thank you so much.
you.
I appreciate your time, and I appreciate you giving the viewers some insight on heart failure and kidney disease. Thank you so much for coming to my channel. And YouTubers, please like, subscribe, and comment below. Thank you. Have a good day.
Thanks. Glad to be here. Thanks.
Thank you.
Bye-bye.
Bye-bye.